Hello, everybody. Welcome to another edition of the AFR EMS Case Studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire. And today we're joined by our Medical Director, Dr. Pruitt.
Hi, Chief.
Welcome, Doc. And we're also joined by Lieutenant Josh Groves.
Morning or afternoon, sorry.
Welcome, LT. Thanks for joining us today. So this was a unique call that you were dispatched to. You were assigned to Engine 2.
Yes, sir.
So Engine 2 and Rescue 2, you all were dispatched out to a 9 Echo, and the information given was that it was a 57-year-old female who is possibly choking. So talk with us a little bit about what are some of the things that are going through your mind en route to a 9 Echo, and then adding the caveat that they're potentially choking. What are the things you're preparing for mentally?
So initially the dispatch, the coding was for choking, and then I believe when we were en route, it went to a 9 Echo. So initial thought, and I actually had a call just a week prior for a pretty severe choking in 3's district that we were successful with. So obviously my first thought is airway. You know, what are we going to get? We obviously got to clear and be aggressive with that airway. And my personal approach to those calls is I get an idea of what the call is, but I try to keep an open mind, because oftentimes we find when we go to the call, it's not what the dispatch was. So that's pretty much what I was thinking.
Yeah, absolutely.
And I think it was late at night, so I was asleep.
Yeah.
So I was really just trying to wake up, I think.
Yeah, that's the most important part, just waking up from those night calls and kind of think it through, because that's not easy. It's not easy to do. So awesome. So then you guys arrived, and you did indeed find the female lying on the floor in the bathroom, and it sounds like she was unresponsive, but she did have agonal respirations. So what all did you guys see when you got there, and what was your first actions?
So when we came into the house was completely dark. The only light was the bathroom light. There was a woman there, and I don't know if it was her daughter, friend, I don't know who she was, but she said that the woman was frantically knocking on her door, and then she heard a loud noise, and then she came out and she saw her in that position, so she called 911. So yeah, she was in a nightgown. Her head was, half of her body was in the bathroom, the other half was in the hallway. Noticed that she just had, if you want to call it agonal resp, either way, we knew we had to move her. So we immediately moved her to the living room, where we thought we'd have more lighting, but unfortunately there was no lighting in the house. So the only lighting we had was from the bathroom. Palpated a pulse real quick, so she did have a pulse. So I asked one of the crew members, let's get her exposed, get the pads on. I asked for the laryngoscope so I could get a look at the airway. And when I looked, I just saw a lot of peanut butter and crackers. So at that point, I asked for suction, got the yank hour. I started suctioning and probably got about a tablespoonish of peanut butter, and it clogged. So suction was pretty much out the door at that point. At that point, I decided to forego intubating with an ET because I was concerned. I didn't know how far that peanut butter went in the airway, and my concern was that peanut butter would clog into the tube. So I figured I would just go with the LMA. More surface area, we wouldn't have to go as deep into her airway, and I thought hopefully we could start forcing some air. I think her initial SAT was in the low 40s, so with the pads on, she was sinus tach. Got the LMA in, secured it, started bagging her, and then was a load and go at that point. And by the time we got her loaded into the ambulance, her SATs had already come up into the low 90s. So at that point, we maintained supportive care, got a line, continued to monitor, got a blood pressure, got a sugar. We never made an attempt to do any more suction or look at the airway after that because her SATs were good. Lung sounds, she was pretty clear up in the uppers, nothing in the lowers. By the time we got to the hospital and we were unloading her, she actually started to buck the tube. So she was starting to have a response. And got her into, was it press that we took her? We told the staff what happened, what we had done. And before I left, which was there probably about 15 minutes, she was verbally communicating with staff at the ER.
That's awesome.
So.
Fantastic save.
Yeah, it's incredible. Talk with us a little bit about, obviously we can visualize that with peanut butter and crackers, hard to swallow in regular populations, like our higher risk populations, kiddos, the elderly. We've talked about history of strokes. What are some other issues that we would look at in terms of an airway with patients of different populations?
I always, with choking calls, probably our most common populations are the extremes of age. So young pediatric patients, we were talking about grapes earlier, a major culprit, Legos, anything that the kids put in their mouth, but also our elderly population. A lot of times if they've had a history of any sort of neurological disorder or a history of stroke, strokes can severely affect the ability to swallow. And they may be used to eating a food that they've eaten their whole life, but all of a sudden, with a sudden change after a stroke, they don't have that coordination that it takes to actually swallow a bolus of food, and it can get stuck, especially if it's a sticky food to start with. So approaching that airway exactly like you did, look in there first to see what you can get out, get as much out as you can, and then you're left with whatever you can't reach. Do I push it in deeper, hopefully like just trying to main stem it, or try to work around it? And it sounds like your decision with that LMA was excellent, because I agree with you that ET tube probably would have just gotten more peanut butter in it.
Yeah, and the concern with that is obviously time is of the essence, and I didn't want to waste doing that, having to pull that out and then go another route at that point. So, and interestingly enough, family members did say because of her CVA, she did have issues with swallowing. So I did advise them on the way out that maybe no more peanut butter and saltines, but we'll see.
Yeah, so fantastic job. So it looks like the initial vitals that were documented, we talked about a heart rate about 134, which matched on the monitor. You talked about the SAT being at 43%. We got a CAPNO of around 65 after the interventions. Then heart rate came down a little bit, 123. SATs shot up to 94%. CAPNO still hung around 60, and then no temps. So otherwise did great. And we started talking about the bucking of the tube. Did you guys have to worry about treating any of that as far as her bucking the tube to calm her back down, or did you guys think about removing the LMA, or what was your thoughts on that?
Since we were in the parking lot at the hospital, she was still unresponsive. So I think she was just starting to have a gag reflex. So I wasn't going to mess with the airway at that point. I figured now the staff, they did pull it. So, and got a look in there, and she was spontaneous respirations on her own, so that was good. I don't know where the peanut butter went, so it'd be interesting on the follow-up if she had pneumonia, or I've never heard of a case where there's pneumonia or peanut butter in the lungs.
You'd be surprised what can get stuck in the lungs after trauma or after an aspiration event, and it not infrequently does lead to a pneumonia in the next couple of days.
Yeah, especially with her age.
Yeah.
Fantastic job. They handled the ABCs early. Obviously, that airway came first. You talked about, you got the information of choking, potentially perpetuating the cardiac arrest, which thankfully was never in full cardiac arrest. As far as troubleshooting the airway, we talked through that. Like the ET2 probably wasn't ideal. I agree. Then going with the going with the LMA was the next best. At what point, Doc, if we're not getting good compliance with either the LMA or if we decide to do an ET tube, at what point are we monitoring for CPR? Are we just looking strictly at the pulse, or is there a point when those respirations are down so far that we would initiate CPR to help along this?
Yeah. So standard teaching is, of course, address that airway first. A comes first in ABCs. But if you're having trouble and it's to the point that there's obstruction, still try to troubleshoot. But if the pulses are lost, you were really wise to get those pads on early and have people ready to do CPR if they needed to, monitoring the pulse. And luckily, she never lost it. But this could lead to a case of a true can't oxygenate, can't ventilate. And then you're kind of going down the path of this would be the situation to consider a crike. If you have some bolus of food stuck above the cords and you truly can't oxygenate and can't ventilate, at some point that would be, and I think the hardest part about a crike is actually making the decision to do it. But the earlier you make that decision, the better it is for the patient. Luckily, we didn't even have to go there, but I don't know if it crossed your mind.
Momentarily.
Yeah.
And I figured she would have been a hard crike too, because she was large neck for sure.
There's a lot of considerations
Hard to
that go
find
into
that
that.
and the fact we had no lighting, that made it more difficult. So, but I mean, I think the aggressive interventions helped us. So.
Oh yeah.
Yeah, absolutely. And I think this was probably the worst case scenario, right? Because you don't have the ability for the McGills to really help you out in that case. You're you can try to write main stem, but essentially you're just pushing through a viscous substance, so it's not the same as having like a chunk of food. So I think you handled it spectacularly. Looking back now, I want to touch on Engine 2 and kind of a unique response as well, but looking back, like for newer providers who are in that situation, is there any like nuggets of information that you would give them, things you would do differently, things that you think went well that you would pass on to somebody who encounters this call?
So my biggest advice to new medics coming into the field, and I see this often, is when it does come to Airway, absolutely be aggressive. Because if you're aggressive and you do good interventions, you usually have a good outcome. Obviously, stay calm and collective. Make sure you're following your ABCs, doing everything that you're supposed to be doing. Aside from that, it's always case by case, dependent on what you're going to have in that airway. And I've had a lot of the FBOs with that, and I've had Snicker bars, quiche, peanut butter, toys, grapes. This was a first. But yeah, I think aggressiveness is probably the best advice I could give people.
Absolutely.
And when you say aggressive, you mean just get in there and look and be ready to pull stuff out?
Yeah, get in there, look, see what you have, and start doing your interventions quickly.
Mm-hmm.
You need to get a patent airway.
Yeah.
So, because if you don't have that.
Yeah.
So you're the lieutenant, obviously, on Engine 2, which is one of our newest ALS engines. And then your counterpart is Rescue 2, which has what we're calling non-preferred staffing with a basic lieutenant and then a paramedic driver. Any challenges, anything that you've seen so far in your time there at Engine 2 that has worked well or could go differently with that response model?
So for me personally, I have enjoyed being on the engine. It's kind of a nice, it's a new approach for me because I've been on the rescue for the whole time I've been here. I think it works well in the sense that, I can take calls for the rescue because I am ALS and vice versa. Oftentimes if we have the critical calls, we're there together. I think it's a benefit to the department because we just have better patient care. We have more apparatus that are ALS provided to the patients. And I've enjoyed it, and I hope this department continues with it and actually explores doing it with more stations.
Yeah, and I think that's kind of been the discussion and the push. Is obviously it's a better product for the end user because there's more ALS capability. You can shorten response times, but ultimately I think the draw has been that career path, right? So for you being a paramedic lieutenant, I think historically there's been one opportunity to get off of the rescue, and that's been to promote to captain. And not everybody wants that role, and not necessarily everybody wanting to be on engines either, but at least gives you that opportunity, that option to still be able to kind of reinvigorate a career and just do something different.
I agree, and it definitely helped reinvigorate for me as well.
That's awesome.
Yeah, so.
Good deal. Well, it's a fantastic case. You handled it like a pro, as always. I'm glad you came out and talked about it because this was unique. It's not a standard choking situation, and the way that you guys thought outside the box to be able to address it, I thought was key. So I really appreciate you coming out to talk to us.
Yeah, thanks for having me up here.
Thanks, Josh. It was a great save.
Thank you.
If there are any other interesting cases that anybody has, feel free to use our SharePoint tab, or you can reach out to anybody in EMS division. Josh was joking about the fact he hates being on camera, so we get it. If you don't want to be on camera, we can still talk about your case, but it's not that bad, right?
No, but has anybody ever told you no?
We've got no's.
A couple.
Really?
We've got no's. and
Most
that's
people
okay,
say
too.
yes, though.
I didn't think I had an option.
There's always an option, but we love talking about the cases. So even if you're not comfortable sitting here having the dialogue, we're happy to talk about it. So we just want more cases. So feel free to reach out. Until then, we'll see you next time. I appreciate you.
Thank you.